Sir, can we start?
Okay, I'll share the screen.
Yeah. Sir, let me introduce you. Good evening, all. On behalf of Bayer Dalutamide team, I welcome Dr. Pratik Patil. He's a renowned medical oncologist at Jupiter Hospital, Pune, and he's having more than 10 years of experience. Today, he's sharing the insights on darolutamide in MHSPC patients. I request Dr. Pratik Patil to start with his presentation.
Yes, thank you so much for giving me this opportunity to speak today. Uh, is the screen visible?
Yes, sir. Yes, it's visible.
Sir, make it a full screen in presentation view.
Now?
Yes.
Okay. So today we'll be talking about early treatment intensification options in metastatic hormone sensitive prostate cancer. So as we know that when we begin the treatment of every prostate cancer, especially metastatic, we always look at the hormone sensitivity of the prostate cancers and treat it accordingly. But also in the cases that are in the early stages of prostate cancer, hormonal therapy forms an integral part of the cancer treatment. Earlier, we used to do only surgeries for such cases, but now it is restricted to hormonal treatment, which gives excellent results without any cosmetic malfunctions. These are my disclaimers. So we'll be talking about HSPC introduction, treatment landscape, and clinical studies. What all data do we have today? Early treatment intensifications in metastatic HSPCs, and then the conclusion. So basically, it can be defined as a de novo, that is a newly diagnosed or recurrent prostate cancer diagnosis following a local therapy. In metastatic hormone sensitive prostate cancer, the disease responds to ADT, which is androgen deprivation therapy, and patients have one or more meds on conventional imaging. So, as we know that metastatic prostate cancer forms around 25% of the patients, whereas rest of the people are non-metastatic, which is 75% of the people. In a non-metastatic HSPC, local disease, generally we do the treatment with hormonal therapy, and then later the patient gets converted into a CRPC, which is a castrate-resistant prostate cancer. Whereas also in the metastatic patients, we first always treat the patients with hormonal therapies if they do not fit into the criteria of starting chemotherapy, which generally happens only with a very large metastatic spread, especially in the axial and appendicular skeletons. So, patients with HSPC can be classified as having either de novo or recurrent disease. Incidence of de novo or recurrent disease varies based on country-specific guidelines, but prostate cancer definitely is getting very widespread in the Indian population now. So the extent of disease progression basically gives us an indication whether what treatment to be used for the patient and what are the outcomes that are going to be in such patients. So we generally stage the patient as per the TNM classification, where T forms for tumor, N forms for the node, and M starts for metastatic cancer, metastatic this. Also, if we look at the volume of the disease and risk of the disease, it is a very significant marker that is considered in the treatment of prostate cancers, because for high volume disease, we generally start with giving a dual combination of therapy, which could be in the form of radiation therapy and hormonal therapy in the early stage prostate cancers. Whereas for metastatic, we generally prefer giving a few cycles of chemotherapy first. Whereas in the disease that is high risk versus low risk, again, the decision making depends upon what is the risk classification and what is the stage of that prostate cancer at that point of time. So prostate cancer treatment landscapes, it is obviously evolved from active surveillance, which was wait and watch technique. We have radiotherapy into play, we have surgery into play, we have androgen deprivation therapy alone into play, and we also have first generation anti-androgen ADTs now that have come. So earlier we used to have the option of using docetaxel and ADT, which was actually as per the Stampede trial and Chartered trial. Then we had options that came up in the form of abiraterone, apalutamide, enzalutamide, combinations of abiraterone with docetaxel, and now we have the option to use darolutamide with ADT with docetaxel, and also darolutamide with only ADT. So in non-metastatic CRPC patients as well, we now have first-line indications to use darolutamide ADT combination or enzalutamide ADT combination for such patients. So what we basically target in the patients of prostate cancer is a good long-term preservation of quality of life, which becomes very significant as these patients are non-metastatic. Second, we have to increase the patient's progression-free survival and also the overall survival in these patients. So depending upon all three these of diagnostic criteria, we decide what treatment would be necessarily important for the patients of prostate cancer. So the standard of care in metastatic HSPC has involved to combine ADT with AR inhibitors, abiraterone or docetaxel. So earlier we used to, like I told you, we used to use only hormonal therapy, but now with the evidence from chartered and standard trial, we also have a combination where docetaxel could be used with ADT and either of the hormonal therapy that we use in prostate cancer. But in spite of doing all of this, we have a large proportion of patients of hormone sensitive prostate cancer who will later on become castrate resistant prostate cancer within 3 years. And that is the main reason why we need molecules that could extend this disease free interval time from which a patient is sensitive and then castrate resistance. So early treatment intensification in metastatic hormone sensitive prostate cancer with darolutamide and abiraterone. We are going to see this trial today. So ARASENS is the only study prospectively designed to investigate combination of darolutamide plus ADT with docetaxel in HSPC metastatic. So it's a global randomized double-blind placebo-controlled phase 3 study where patients who are metastatic hormone sensitive prostate cancer, good performance status, candidates for ADT and docetaxel, they were stratified on the extent of disease, being it M1A versus M1B and M1C, and alkaline phosphate level of below normal to more than normal. And they were randomized 1:1 to docetaxel into 3 cycles with a combination of darolutamide, 600 milligrams BID, plus androgen deprivation therapy. Whereas the second arm consisted of placebo plus ADT and docetaxel only. And the final analysis was conducted after 533 deaths, and secondary efficacy endpoints were tested hierarchically. So the first cycle of docetaxel was administered within 6 weeks after the start of study drug at the discretion of investigator. Endpoints, primary endpoints were overall survival. Secondary were time to castrate sensitive prostate cancer, time to pain progression, symptomatically skeletal event frame survival, and so on. So this basically trial also includes piece one, which was not prospectively designed to investigate the combination of the prednisolone abiraterone with ADT and with docetaxel, but it was a retrospective analysis. So this includes de novo M1 recurrent metastatic patients and patients who had taken prior chemotherapy, and that is why a trial had to be constructed in a prospective fashion where this could be studied in a prospective way so that it could give us a true sense of when it to be used. So this has basically randomized into two arms where arm A was standard of care, arm C was standard of care plus radiotherapy, and arm B was abiraterone prednisolone combination with standard of care protocol. So piece one was amended basically to allow for evolving standard of care with docetaxel, and docetaxel was made mandatory as a part of protocol. So in ARASENS trial, all 1,300 patients were enrolled, received docetaxel versus 710 patients who were enrolled for piece one trial. So ARASENS trial, this was conducted in recurrent or de novo HSPC, whereas piece one was in de novo HSPC only. Primary endpoints were OS for both, whereas PFS was also included for piece one trial. Stratification factors, ALP11 and extent of disease, as we see in ARASENS trial, whereas for the piece one trial, we had type of castration, ECOG performance status, extent of disease, and docetaxel. So if you look at the basically pre-planned analysis, 100% of the patients had received ADT plus docetaxel in ARASENS trial, whereas in the piece one trial, only 61% of the patient had received docetaxel and ADT. So that is why the significance of ARASENS trial becomes extremely significant in the treatment of prostate cancers. So darolutamide plus ADT with docetaxel had significantly reduced the risk of death by 32.5%. As you can see, at the end of 48 months after randomization, the overall survival is 63% as compared to 50%, and the hazard ratio also appears to be significant of 0.68 percentage with a significant p-value. So here, with the addition of darolutamide, the 4-year survival rate had increased from 50% to 63%, which marks a very important journey in the treatment of HSPC metastatic prostate cancer patients. Whereas if we look at the PIS1 docetaxel subgroup, we can see that abiraterone, prednisolone, and ADT with docetaxel had significantly improved OS compared with only docetaxel and ADT, with a risk reduction of 25%. So obviously, with addition of chemotherapy to the hormonal therapy, we know that now the overall survival of these patients is increasing, which is giving them a better DFS as compared to before. So unlike in PIS1, in Arasens, there is an early separation of the Kaplan-Meier curve, and the lines remain separated over time, which was not seen in that of the PIS1 trial. So looking at the safety profile, we can see that patients who were on darolutamide had a better survival as compared to that of the patients who had only ADT and placebo. The median follow-up duration was around 43 months, and also the median follow-up duration was 53 months in the PIS1 trial. So treatment discontinuation due to side effects is similar in between both the arms, whether you add darolutamide or you do not add. So that means that with the additional addition of darolutamide with ADT, with a combination of ADT and docetaxel, there were no excessive side effects that were expected with the arm. So the tolerance of this triplet combination was also very, very well. Also, darolutamide did not affect the ability to complete full cycles of docetaxel, in which 6 cycles were necessarily given to all of the patients. So proportion of the patients who completed 6 cycles of docetaxel in each treatment arm were 87.6% as compared to 85.5%. So the tolerance level of this arm was also pretty much well matched. In Arasens, the incidence of any grade adverse events were similar. If we look at the grade 3 and beyond, the difference was 38% as compared to 35%. So not a very significant difference that we can see in both the arms. Also, in the Arasens trial, the incidence of adverse events was generally similar between the treatment arm. The rates of fatigue were 33 to 32%. Vasodilation and flushing was 20% to 21%. Rash was also similar. Diabetes mellitus and other complications were also similar. So hypertension and rash were the only 2 side effects that were seen to have a little bit worse effect with darolutamide arm than in compared with the placebo arm. Also, if we look at the toxicity that was more than grade 3, there was 63% toxicity that was seen in the abiraterone, prednisolone, ADT, and docetaxel arm, whereas in the only docetaxel arm, the side effects were also 52%. So even with this combination, we can see that a lot of patients were facing complications. So looking at a closer look on why there is a need for adding darolutamide and docetaxel, which have a potential synergistic effects which enhances the clinical benefit. So preclinical models have demonstrated that targeting the androgen receptor pathway enhances the taxane-induced cellular apoptosis. So docetaxel is a microtubule depolymerization inhibitor, which impairs the mitotic progression, leading to cell cycle arrest at M1 anaphase. And darolutamide is also a potent androgen receptor inhibitor, which blocks the nuclear translocation of the androgen receptor, preventing growth and promoting apoptosis of prostate cancer cells at the G1S transition. So in vitro and in vivo, both studies have shown that targeting the AR with the AR inhibitor enhances the efficacy of docetaxel or cabazitaxel. And also abiraterone is a ARPI inhibitor that inhibits CYP17, which blocks the conversion of androgen precursors to testosterone and DTH. So darolutamide, we know that it is indicated for the treatment of the patients with non-metastatic CRPC and also with hormone-sensitive prostate cancer in combination with docetaxel. It has to be used with caution in the patients with ischemic heart disease, seizures, and embryonal fetal toxicity, and also in the patients who have skin rash or hypertension. Whereas abiraterone is indicated in combination with prednisolone for the treatment of patients with metastatic CRPC and high-grade metastatic HSPC. What are we looking for when treating abiraterone is mineralocorticoid excess, adrenocortical insufficiency, hypoglycemia, hepatotoxicity, embryonofetal toxicity, and increased fractures and mortality when especially combined with radium 223 treatment. So we looked at the side effect of both the drugs, and we also should be knowing that in the patients who have cardiovascular comorbidities, especially in the form of hypertension, we need to look for symptoms of mineralocorticoid excess. Whereas also in the patients who have diabetes, we have to monitor their hyperglycemia and hypoglycemia as well. Hepatotoxicity, liver function monitoring once in a month at least should be done. For adrenocortical insufficiency, increase the dose of corticosteroids initially, and then later it can be tapered off to minimum. And decrease bone mineral density, cardiometabolic toxicity, such as aggravation of hyperglycemia in the patients of diabetes and hypertension should also be looked for. So these monitoring requirements, they definitely contribute to a significant burden of the patient, physician, as well as the healthcare system, which can give a better quality of life to the patient. So abiraterone basically is associated with unique mineralocorticoid related adverse side effect reactions that we know. It is also seen to increase the progression of hypertension or cardiotoxicity. Also, there are case reports that are known for patients to land up in heart failure. So cardiovascular management is extremely important. That should be looked very closely with the use of abiraterone. Additional meta-analysis and pharmacovigilance studies also report an increased association between abiraterone and cardiometabolic adverse events. So lipid abnormalities, triglycerides excess, water retention, hypokalemia, and hypertension and body rash are something that you need to be very observant with using abiraterone. Darolutamide, it has a low risk for clinically relevant adverse side effect reactions, which may lower the burden of managing comorbidities. So, potential drug reactions that can be seen with the use of darolutamide are with the drugs that you can see, which generally involves calcium channel blockers, digoxin, proton pump inhibitors like omeprazole, fentanyl, quetiapine, diazepam, midazolam, antibiotics like clarithromycin, rifampicin, statins like rosuvastatin, and antithrombolytics like rivaroxaban, clopidogrel, dabigatran, and warfarin. So we have to look for interactions with these medicines. We have to look for diabetes, depression, dyslipidemia, arthritis, arthralgia, constipation, obesity, and hypertension, and also skin related problems in the form of skin rash. So definitely with the trial that we have seen, with the data that we have seen, darolutamide sets a new standard for the patients for metastatic HSPC. It is a potent androgen receptor inhibitor with robust efficacy and a favorable tolerability in the patients with metastatic HSPC. It has also got darolutamide has got a low risk for clinically relevant DDIs, which may lower the burden of managing comorbidities. And also, darolutamide requires minimal patient monitoring, which makes it a safer drug for use, especially in the patients of prostate cancer who are elderly population who have been diagnosed after the age of 70. So key takeaways, darolutamide is the only ARPI prospectively tested and proven in combination with docetaxel and ADT to prolong survival and delay disease and pain progression for patients with de novo and recurrent metastatic HSPC. Darolutamide is the only ARPI to demonstrate strong efficacy with more than 30% reduction in the risk of death with combination of docetaxel ADT and a favorably tolerability profile with minimal additional side effects in the patients with metastatic HSPC versus docetaxel and ADT. Discontinuation rates due to adverse events were similar in between darolutamide plus ADT with docetaxel arm and the placebo ADT and docetaxel arm, which was 13.5% as compared to 10.5% respectively. Also, Peace One, which is with the abiraterone, is an open label study, investigated the combination of use of abiraterone, prednisolone plus ADT only in the patients with de novo metastatic HSPC, and the study design did not originally include use of docetaxel, but later had modified the use. Here, the PFS as well as the OS showed a 25% reduction in the risk of death, which was significantly improved in the patients who received abiraterone prednisolone with a combination of ADT and docetaxel. So abiraterone prednisolone with combination of ADT and docetaxel was also associated with additional risk of severe hypertension, hepatotoxicity compared with ADT and docetaxel. And also the discontinuation rates due to adverse events were higher in abiraterone prednisolone plus docetaxel arm compared with only docetaxel. So thank you. This is all about the presentation from my side. And if there are any questions, I would be happy to take them.
Thank you, sir. Thank you for your time. So there is no question, but we want to inform you that the darolutamide now is now approved with the doublet regime. Those patients, those who are not chemo fit patients. So with ADT plus darolutamide combination, you can treat the patients of MHSPC.
Definitely. Yes.
Yeah. Thank you, sir. Thanks for your time and sharing your insights on the MHSPC management patients, sir.
Thank you so much.
Thank you, sir.
Yeah.
Hello, sir. Hello, sir. Hello, sir. Can you hear me? Hello.